Good morning, everyone. I am Mahmoud, the lecturer of Gender and Pediatric Pulmonology, Karam University. Ahmed Said is a 7.5 years old male patient. He is the first child of Down concerning his marriage. The condition started at age of 2 months with vomiting, moderate diarrhea up to 6 times per day, large in amount with offensive odor and urination. The condition was associated with respiratory distress and required fecal admission in a private hospital for 5 days. And after stabilization, the patient was referred to Upper Reach Hospital for further investigation. Since then, the patient had recurrent attacks of vomiting, diarrhea, and dehydration, electrolyte disturbance in form of hypokalemia and hyponatremia, and chest infection about once monthly that needed recurrent hospital admissions. At age of 6 months, the patient presented to pulmonology clinic with severe prescribed gastroesophageal reflux and recurrent chest infection. Electrolyte was done and was negative 15 milliequivalent per liter. At age of 9 months, the patient was suspected to be Porter syndrome due to persistent hypokalemia, hyponatremia, and metabolic acidosis, and was referred to the nephrology clinic. His family history showed 2 sampling medicines. The child died at day 1 due to respiratory distress, and the second had the same manifestation to our patient: attack of vomiting, diarrhea, dehydration, recurrent chest infection, and died at the age of 5.5 months without diagnosis. The patient was free. The first sapling died at day 1, while the second died at age of 5.5 months with the same manifestation to our patient who died without diagnosis. This is our patient Ahmed, and after Ahmed, the mother got pregnant twice, and antenatal diagnosis was done for one of them and aborted. Diagnosed with the same mutation to our patient. Whole exome sequencing showed homozygous pathogenic variant was identified in the CFTR. The genetic diagnosis of autosomal recessive cystic fibrosis was confirmed. Sweat pride test was repeated after the result twice and was 98 milliequivalent per liter. Flexible nasal pharyngeal ureteroscopy was done, revealed paired with severe swallowing disorder. CT chests were done annually, and the latest one revealed bilateral diffuse pulmonary ground glass feeding with area of air trapped. The last CT chest. Sputum culture were done regularly. The latest one showed pseudomonas. Pulmonary function test was done and was over. Management, airway clearance technique, bineutralization, bronchodilator, hypertonic saline, eucalyptic acetylcysteine, and inhaled antibiotics. Chest therapy, systemic antibiotic, according to culture insensitivity, when the patient presented with resuscitation. Enzyme replacement therapy, iron and multivitamins added with the doses adjusted after the nutrition clinic recommendation. RS and oral potassium, we recently the patient started Trikafta 1 month ago. The weekend high, we have to use the third percentile, so the nutrition team will put a nutritional plan for this patient. It's containing the nutrition plan with Dr. Yasmeen.
Good morning, everyone. My name is Yasmeen. I'm a lecturer of pediatric clinical nutrition. This patient was referred to the nutrition clinic at the age of 5 months for nutritional assessment and planning. His problems to us was severe failure to thrive, gastroesophageal reflux disease, and swallowing dysfunction. The patient received a nutritional plan. He was not yet diagnosed as cystic fibrosis. He received a nutritional plan including the initiation of enteral feeding through a nasogastric tube, anti-reflux measures, and a high-calorie formula was prescribed to meet his specific caloric and nutritional needs. After confirming the genetic diagnosis of cystic fibrosis, the patient was started on a nutritional plan tailored to his condition. We estimate the caloric needs of these patients at 110 to 200% of the recommended intake for a child of the same age and height without cystic fibrosis. We did basic laboratory investigations including CBC, serum electrolytes, calcium profile, liver enzymes, serum albumin, and most of them showed normal results. This is the macronutrient distribution of our meals. 40% of the recommended energy should come from carbohydrates, another 40% from fat, and 20% from proteins. This slide shows us breakfast ideas from our local Egyptian cuisine. We have this dish. Everybody knows it. It's food. It's a fava bean dish, and it's having some tahini on top and oil. We have also shakshuka, which is fried egg with vegetables, tomatoes, and peppers. And we have the famous falafel. Everybody knows it also. And we have futir. Futir is like a layered pie. It's a layers of dough with ghee. So it's energy dense and also nutrient dense. All of these meals can be complemented by salads and extra protein from eggs and cheese. Lunch ideas also. So I'm getting you to get hungry. Okay. Maybe you've tried some? Okay. So this is the famous kushari. It's layers of rice and pasta and black lentils and chickpeas. Topped with tomato sauce and fried onions, and we have this rose ma'amar. Okay, so this is cooked rice and milk and sour cream, and it's also cooked with ghee or butter. And we can add some protein such as chicken or beef or pigeons. Okay, so we have also our local version of lentil soup and a beef stew. Snack ideas, the patient could snack on anything. We encourage fruits. We encourage also dates with stuffed with sour cream or chocolates, topped with nuts. Also cooked wheat grain with milk, topped with raisins and coconut. We have the same also with rice pudding. So anything that's energy dense and nutrient dense is accepted. And it depends also on if the patient can afford it or not. So we have a variety of foods according to the patient's financial status. We also supplement the patients with fat-soluble vitamins, zinc, calcium, folic acid, omega, according to the tailored supplementation schedule. This is our supplementation schedule in Cairo University hospitals, according to the age of the patient and the dosage of the medications. We supplement according to this schedule. We give oral rehydration solutions to increase the sodium intake, especially in summer and at the times when the dietary intake is low and during the periods of fever and diarrhea. As the child grew older, the mother was advised to increase his salt intake by offering salty foods such as aged cheeses and pickles, and to use the oral rehydration solutions when necessary. Pancreatic enzyme replacement therapy was initiated at the pulmonology clinic. The doses are adjusted according to the frequency and the consistency and adherence of the bowel motions and the estimated daily fat intake. Since then, the steatorrhea of our patient improved markedly. Proton pump inhibitor therapy is prescribed to manage the associated gastroesophageal reflux disease and to reduce the gastric acid secretion to optimize the PERT efficacy. Regarding the PERT, the capsule's contents are empty when the child is younger and he can swallow the capsules. The capsule contents are emptied and appropriately dosed. They were mixed with homemade apple puree, boiled with mashed apples, then administered before meals. As the child grew older, he developed the ability to swallow the capsules whole. The patient also required oral nutritional supplements as an integral part of his nutritional plan to increase the caloric intake He alternated between partially hydrolyzed formula with high concentration of MCTs and polymeric formulas. This is the growth curves of our patient. He fortunately achieved catch-up growth from since his time of presentation till the age of 5 years. His weight was between 0 and -2 standard deviations z-score. As for his length also increased and reached at the age of 5 years -2 standard deviations z-score. His weight for length was between 0 and 1 standard deviation z-score. His last follow-up at our nutrition clinic was 7 years. At the age of 7 years and 5 months old, his weight was 21 kilograms between the 3rd and 10th percentile. His height was 113.5 centimeters below the 3rd percentile, and his BMI was 16.2 at 0.3 standard deviation z-score. These are his growth curves. We can see here that after the age of 5 years, his growth declined slightly, and he was more on the low side, below the 3rd percentile for his height. As for his weight, also he crossed the centiles. This is his BMI. We can also observe that his BMI curve is still within the accepted normal range, but he crossed centiles. So we can explain this, that the patient had consistently fallen below his target caloric intake, particularly during the recent follow-up visits. This could be attributed to disease-related anorexia, limited family resources preventing the access to highly nutritious food, and the steatorrhea resulting from intermittent shortages of the pancreatic enzyme replacement therapy. During his most recent follow-up visit at the 25th of March, a trial of Trikafta, the CFTR modulated therapy, was started to the patient as part of his ongoing care. Thank you.
Great presentation, both of you. Good job. Now I have a question about the age of diagnosis. So you did the sweat test at 1 month of age and it was negative. Is that correct?
الوس
Sweat.
First sweat كان 6 months.
At 6 months and it was like 15 or 19, something like that.
15.
And yeah.
Probably malnourished.
So what kind of, is that nanoduct or the regular macroduct?
In our unit, it was made in our unit.
Okay.
Yeah. Maybe he was dehydrated or malnourished at that time.
Well, malnourished will give you high sweat, so maybe dehydrated would be.
Dehydrated.
Yeah. Okay. And then when did you repeat it again?
11 months after the result was.
But you did the sequencing first, right? Or you did the sequencing after the second sweat?
The sequencing was before the second.
Before
Yeah.
Before the second.
9 months requested was.
Okay.
والريزلت تيجي تايم طبعا شهر أو شهرين وبعدين السؤال برايم
Was repeated after we found that the WES directed us towards a variant of cystic fibrosis.
Right. So
we repeated the sweat fluoride test.
Right. In my center, I would have repeated the sweat test before I would have done the sequencing.
Okay.
Because the sequencing is not like the sweat test is a gold standard still. So that's what I would have recommended. In fact, it's repeat the sweat test. He was dehydrated. Repeat and make sure, because negative sweat, well, he's sick, he's dehydrated, you don't know. So yeah, I would have repeated it again. But you kind of reach the diagnosis.
Yeah.
Right?
In a difficult way.
Yeah.
More expensive way.
And it would be really interesting to see what he'll do with the Trikafta because it's known to increase the weight. So we'll see how that will happen.
Still waiting for
Yeah.
still 1 month.
Yeah. Stacey, do you have any questions?
When did you check a fecal elastase? Did you wait until the second sweat and genetics?
It's not a routine in our clinic.
Because I was wondering if you could make intervention sooner if you had tested the stool samples
We
before
test
you
stool
do the next
analysis.
sweat.
We test for fat in stool. fat globules in the stool. But fecal elastase is not like a routine. It's very expensive, and sometimes it's not available. It's not available in most of the.
Did you?
No,
Did you?
But some they didn't think of CF at the time.
Oh, okay.
That's why they kept working on him, seeing what's going on, and then like, oh, maybe it's CF. They did the sequencing, then they repeated the sweat when it was clearly possible. So, yeah. But yeah, no, I think that the Ministry of Health mean the fecal elastase, but I think it's hard to get it.
It can be repeated routine.
You don't want to do it all the time, but you want to do it in a situation like you're not sure of the diagnosis, that will help you kind of thing.
I think it's a tedious process to go through the insurance to make some tests and stuff. Yeah.
Right.
It takes a long time.
Yes.
Thank you.
Thank you very much. Good job.